Hello, everybody. This is Shannon and Dr. Mike from the Dr. Mike and Shannon Show, and we are so excited to present to you our Pelvic Party webinar that we did with Dr. Mike Bradley and Debbie Folkert, the founder of the Uravel BRS, where we talk all things pelvic floor and how the Uravel BRS system works in conjunction with that. Mike, go ahead and discuss a little bit about what we talked about.
Well, we emphasize a lot on this particular webinar, which was really good. It's about an hour long. There's some great conversations. We had a chance to talk to a pelvic floor physical therapist a little bit about some of the stuff they do. And we also have a couple potential guests that might be coming on the Mike and Shannon show here pretty soon. So we're excited to get some of these people in there. But in it, we're really focusing on gynecology and how the BRS system and gynecology work hand in hand with people with incontinence issues. So there it is.
Yep, we had gynecology, urogyne, and pelvic floor therapists joined us. So great video to be able to watch, and we hope you enjoy.
Okay. All right. Well, greetings, everyone. It's really nice to be having you as a part of this webinar. I am Dr. Mike Bradley, PhD. I'm the Chief Medical Officer of Mazan Medical. We are a distributor that is proud to represent the Uravel bulbocavinosa reflex system. I am one of the authors of the paper, the UNLV medical paper, specifically on pelvic floor rehabilitation and how it was guided by the bulbocavinosa reflex, specifically the Uravel, in our process to be able to help women that were dealing with urinary and adult incontinence. I have with me tonight Miss Debbie Folkert. Miss Debbie, if you would be so kind as to introduce yourself, tell us a little bit about yourself and a little bit about this wonderful device, the Uravel, and how you kind of came up with it. Kind of give us the full meal deal, if you will.
Thank you, Mike. My background is that as a nurse practitioner. Historically, urology has been most of my practice for over 34 years. And so needless to say, I've seen about every type of patient there is, but my special niche in the practice was to see those with incontinence, voiding disorders, pelvic floor disorders of all types, even also fecal incontinence I dabbled in also. And as a nurse practitioner, one of the things when I was getting the patients to evaluate, and they would give me the long histories of how long they'd had issues with bladder dysfunction, everything they had tried, procedures they had underwent. I always thought to myself, okay, I want to know a couple of things. I want to know, number one, is this muscle or is this nerve? Which track are we going down here? And so I started to look at I really wanted to find something that I could do a reflex study with that would tell me very fast if I was dealing with a sacral nerve issue, because my treatment approach was going to be very different. And one of the things that I really try to not do is have a trial and error approach of saying, well, let's try this, and if it doesn't work, we'll go to the next drug, and we'll go to the next drug, or we'll try a procedure. Let's hone in on what the real cause is so we can treat it better and give better choices. As I was looking at this, I also was approached by several nursing homes, and that one of the things that Medicare requires is an evaluation if they're incontinent. And I thought, wow, if I just, especially in the nursing home, you get the most difficult patients there are. I'd really like to have a device that tells me where's the etiology of this issue, or at least to be able to hone it down. So I decided to Google and see if there was anything that did a bulbocavernosus reflex with latency time, because we're taught to do a bulbocavernosus reflex when we're in school, but they don't teach us the important part of that. Not that it's just there, because most people have one, but how fast does that reflex response happen? Because if it's over, if you're doing a mechanical reflex, it's over 45 milliseconds, then you're dealing with most probably a sacral nerve issue. So I wanted something fast, non-invasive, not uncomfortable for the patient, that could give me this information. So as I researched it, and I, of course, went through all of the device searches, etc., the only thing I could find was electrical stimulation. And, stimulating those parts is not very comfortable. I don't know if they'd be back to see me again. So I decided that maybe one thing I hadn't done in urology yet was invent a medical device. So at that time, I was working with another nurse practitioner, and we'd done a lot of incontinence, pelvic floor therapy, many things. And so we decided to go down this path of seeing about inventing a medical device, because there was a code for it in CPT. And I'm probably one of the few clinicians that has read the entire CPT book to find that code. And there was a code, but there wasn't a device. So therefore, we go down the path of inventing the device. Unbeknownst to me, dealing with FDA and many other things that you find along those paths. But at the conclusion, we had a nice little device that is very portable, easy to manipulate, and easy to do the procedure. Ancillary personnel can do it in the office, and you have a report very quickly. So with that said, we had the device that I had always wanted. Is the sacral nerve involved? Moreover, I can see if it's a left issue, a right issue, or a combination. So with that, it led us down the path of the bulbar cavernosus reflex device, putting it on the market so we can get that very fast result in office of a reflex, not difficult for the patient, and we have a wealth of information.
So in what you said there, just to kind of break it down from the perspective of what we did at UNLV, being able to determine and my students to this day, they always come up with ways to be able to remember, these great little sayings that they come up with, but they say S2, 3, and 4 keeps poop off the floor. Now, I know you talk about, the fecal incontinence issue, and we know when we're looking for the anal wink, or the bulbar cavernosa reflex, they are looking for if there's degradation of the sacral pedonal nerve, and that helps us to determine if we can tell that there's a neurological issue, whether or not we're going to be successful in for example, what we did, a pelvic floor rehabilitation program using electrical stem. Now, there's a lot of things we could talk about this, but on the for the purposes of this panel discussion, and specifically this webinar, we wanted to talk about gynecology specific. So I think about a gynecologist, and a gynecologist generally doesn't have as many tools in their tool belt as what a urologist might have, so to speak. But that being said, they're probably the ones that are almost the front line in showing patients, specifically adults, with urinary incontinence. Wouldn't you agree that they're probably, if not the primary, the gyno seems to be the one that gets that more than almost anyone else? Wouldn't you agree, Debbie?
I do. I think that's spot on, especially, with the population that they treat. They're going to be that first line where they present.
And so when we look at what we found with the white paper, and I'm going to bring it up in just a little bit so everybody can see, we'll also be able to provide, if anybody wants a link to the white paper, it is publicly accessible. The white paper was published, I believe it was peer review published with the Elmer Press. And we also correlate it with the Merck manual, which is a great guidelines that people should use when they're dealing with adult incontinence. The paper specifically talks about the significance of being able to diagnose using the bulbar cavernosa to kind of determine if pelvic floor rehab, specifically with the electrical stimulant we used, is going to be successful or not. And based on that latency time, or the delay in that nerve reaction and the symptoms, we're able to determine that pelvic floor rehab, as we did it at the School of Medicine, had a 93% success, something like an 87% success rate with a 93% satisfaction level 2 years after we got done treating them. So there's a couple things that I want the group to understand. We use this device to be able to help people that are dealing with a problem that has as much anxiety associated with it as full-blown depression. So as physicians and as medical professionals, we're always looking for a way to be able to better the life of our patients. That's something I hear Dr. Levy talk about all the time, that, if we're not helping people, why are we doing it? That's kind of that teacher mindset, if you will, in the UNLV, in the medical school, and how it is. So one of the things I'd like to share with the group, if you'll allow me, is I'm going to share my screen, and I am going to show you this white paper that we're talking about. Now, this is the Elmer Press. This is where you would find it. The title of this, of course, is Bulbocavernosa Reflex as an Objective Measure of the Improvement Following Directed Pelvic Floor Rehabilitation for Treatment of Urinary Incontinence. And of course, Dr. Levy, who was going to be with us, is on here, and myself is on here as well. I was going to pick on Dr. Levy, Debbie, that I was told that the most important people in the paper are the ones that are labeled last. So I guess in our paper, it was first Dr. Levy, and then I was in there. So I guess that's how that works. Is that your understanding how white papers work?
Absolutely, that's how they work.
That's how they work.
Absolutely.
Yeah. So he's the top guy, and I'm just that little guy next to him. So I guess that makes sense. But for the purposes of talking about this paper, I'm going to read a little bit specifically about the method, right? And then quickly the results. So this was a retrospective case series of 95 women with urinary incontinence, right? Meaning that we had done them already. We didn't do it for the purposes of the white paper, but we saw this very noticeable result. And anytime you're doing a white paper with 95 patients with all similar problems, that's a pretty significant number of people. So I want people to understand that this was not a low-level white paper by any stretch of the imaginations. We did a huge sampling of population. We worked with them based on them having abnormal bulbocavernosa reflexes and having symptoms that they wrote out. So they wrote out symptoms saying that I have urinary frequency, I have urinary urgency, and we wrote the questionnaire in such a way that it wouldn't be embarrassing, because one of the things that we found is that a lot of patients are very embarrassed to say, I have urinary incontinence, I pee my pants. They have real problems with that. But they will say, I get up 5 times a night to go to the bathroom. They will say, oh, I have to race to the bathroom because I don't have a lot of time to get there in order to go. Even though these are also underlying symptoms that generally, if you pry a little bit and get them to open up, they'll say, yeah, I wear a pad, I wear 5 pads a day to be able to soak up the urine that gets into my underwear. So these are the patients that we did. They filled out the form. We did a bulbocavernosa by the URAVAL. This test result showed delayed latency in every one of them. And our statistics show the mean number of delayed latency that we would normally get. We treated them for 6 to 12 weeks of pelvic floor therapy. And at the end of that, we had, a very incredible response. We used we used Bootstrap and some of the confidence-based protocols for white papers to confirm our numbers. I had a statistician and I had a bunch of medical students that are listed here that confirmed the data, because they didn't want to take the guy that was doing it, and they didn't want to take the guy that was overseeing the guy that was doing it. They wanted independent people to be able to confirm the research. And the results of this was that the bulbocavernosa went from a mean average of 85 milliseconds on average down to 35.4 milliseconds on average at the end of treatment. Now, Debbie, you just said that 45 milliseconds or less is considered normal, correct?
Correct.
We took a group of individuals that had a mean number of 85 milliseconds delayed and brought them all down to normal latency time. So one can deduct that normal latency and urinary continence control can go hand in hand. Debbie, would you say normally if the problem was a neurological issue and we fixed the neurological issue, that the symptoms would most likely disappear as well, correct?
Absolutely. And one of the things that's so powerful with this paper is that we did not have any way of really measuring an outcome, or, I mean, we would know that they say, yeah, we're getting better, but we did not have an objective measurement of what we were really doing with the nerve. We could measure the muscle, but we had no concept of how much we were affecting that nerve, which again then likewise affects the muscle. So this was very powerful, and especially too with the Hertz frequencies that was used in this to determine. That's something that's still new. They're still using a lot of old Hertz frequencies, which is probably why, you know, with pelvic floor rehab, there's so many variations in the percentage of improvement, and how people do with it is because the Hertz frequencies are basically, especially with overactive bladder a lot, targeted very low at 12.5, and here we use 200. So I think that has a lot of impact.
I had an opportunity to talk with some of the writers of those original white papers from like the 60s, I think, were most of them that came from, where they were doing Hertz frequencies into the 12.5 and very low levels. And I asked the question, you know, why is it that nobody ever checked that, you know? And the answer was, well, we were getting, you know, it was all we had, and we had some results. Well, the reality is nobody really checked it. And I think that to your point, Debbie, what we found as a result at the end of this retroactive study was that Hertz frequency had a direct impact on the neurological response of those patients. And it wasn't just what a lot of people do with like biofeedback, where they're really just exercising the muscles. It was a true improvement of the neurological reflex, which we were able to show on this white paper and with these results. So I thought that was incredibly interesting. And just to continue down that path of how this is starting to show up a little bit more commonly, I'm going to share my screen again to this. Let me see if I can get it for you guys. So this right here, can you see that, Debbie? Can everybody see that's the Merck manual? The Merck manual is fantastic. It's one of our guidelines. It's what a lot of people use is, you know, kind of how they go about treating people. And I simply typed in here urinary incontinence in adults, and it gave us the protocol that most people use, you know, when evaluating patients. And what I find is interesting is they talk that first you should look at the history of the patient, which is similar to what we did with the questionnaire that asked about, you know, how many times do you get up at night to go pee? You know, do you ever lose urine when you sneeze or cough or laugh too much? All of those questions that we used are part of that, you know, understanding the history of the patient. And then it runs right into the physical examination, where neurological is the primary focus of that initial physical examination. And if you look just below on the Merck paper, you're gonna notice these 4 dots that talk about how you can do that. And you'll notice that bulbocavernosa reflex is right in there, along with anal wink, right? Along with anal sphincter contraction, which is also anal wink. So taking from not only this paper as a guideline, but also from you know the results from the white paper, you've got the Merck manual that tells us that we should be doing this on every patient that shows incontinence. We have a white paper that says we've kind of figured out a fix to this if it's urinary incontinence, if it's neurological based, right? And you know, you tie it into kind of the final thing that I'm going to share with you guys, which is that same Merck paper, and something that they specifically say up here: perils and pitfalls. Most patients are embarrassed to mention incontinence, so ask all adults about incontinence. All adults about incontinence. Now, Debbie, from your perspective, when you see something like that, where you've got kind of our guidelines telling us that what you wanted to find quickly and pain-free, right, should be something that's done on all adults to some extent because they're too embarrassed to talk about it, that makes me feel like your particular invention really has a place in medicine based on everything that's going on right now. And just to point out that the Merck manual, that was updated like September of 2022. It's pretty new, less than a year old. So if anybody's ever not seen that, or that's the first time they've seen it, it's because it's brand spanking new. But we're seeing from OGS and different groups now that pelvic floor rehabilitation and understanding pelvic floor rehabilitation has become a much more interested aspect, and something that we should definitely take our attention and look at. So what I'm going to do right now is probably go through a little bit about what we actually do at UNLV. Do you think that would be appropriate, Debbie? So that the people that
I think that would be very helpful.
So let's go through exactly what happens. So I work at a OBGYN department. I don't even work at a urology office. I work at an OBGYN department that sees a lot of postpartum patients. And we saw a lot of women in general, because the School of Medicine focuses on patients in the Las Vegas area that are underserved, a lot of Medicaid, a lot of financially driven people to our location for this kind of testing. So when we have a patient come in for an annual, or coming in for a postpartum visit, we ask them to fill out a questionnaire. And that questionnaire can be anybody that wants it. I'd be more than happy to share it with them. That questionnaire really talks about urinary issues, fecal issues, and sexual function issues, along with a little bit of pain, right? Because we have 4 things that kind of occur in our pelvic floor world. We have urinary frequency, urgency, stress incontinence, nighttime frequency, incontinence without awareness. We have fecal issues, smearing. It's so funny how many times I talk to patients who I'm not fecal incontinent, but I have to wipe 50 times to clean my butt, right? Pelvic pain. We see pelvic pain all the time. And boy, if pelvic floor rehabilitation isn't a great fix for that, I don't know what is, because seems like we're always putting them on birth control and all these hormones and all these other different things, when I think a small little nerve test might tell you that pelvic pain is actually referred pain because of some neurological issues based on some back issues. Maybe because you had that kid in your belly for so long, right? Pooped out a football, and we expect you to be magically better, right? And then, of course, sexual function issues, which I think is very interesting, because for men, and when we talked about urology for men have every blue pill on the planet, right? We've got everything that we could ever want. Women never seem to really get a lot when it comes to sexual function, right? I hear, do your Kegels, do your Kegels, do your Kegels. And 90% of the time people are teaching those wrong, if they're teaching them at all. Right, Debbie? So when we looked at what we did, we took that first part, that assessment of symptoms. And based on that, we then did a bulba cavernosa reflex on those initial visits. If the bulba cavernosa showed a delayed or abnormal time beyond 45 milliseconds with symptoms of anything that I just talked about, that was a very good candidate for a direct referral to pelvic floor rehabilitation therapy. Now, I want to stress pelvic floor rehabilitation therapy. I hear too many times pelvic floor PT, pelvic floor physical therapy. Coding becomes kind of an issue and a challenge for some of our PTs out there. And if any PTs are on this call, they'll know what I'm talking about when it comes to being able to do pelvic floor rehabilitation, similar to what we did at the School of Medicine. That being said, I'd be more than happy to share that protocol with anybody that wants it. They would then come in and we would do an assessment on their muscle strength, their muscle control, and whether or not they had spasm when they did exercises of the pelvic floor. We would generally do it rectal, and we would do that rectal squeeze, because remember, we're checking the anal wink. So why not check the actual anal muscle, the bulba cavernosa in the back, to be able to determine if they have strength, if they have consistency of strength, and they, all of the different things associated with that particular part of it. So with it, we would do what they call a rectal study, or a urinary anal study. We would also at the same time do EMG on the stomach. The reason we would do that is because 9 times out of 10, women were compensating their weak pelvic floor with their stomach muscles. And when they would do this, they would sneeze and cough, and then that muscle would engage, and the weak muscle would show itself in symptoms, meaning stress incontinence. And that's why we needed to teach women to not use their stomach to compensate. So that's why we would do an EMG study at the same time we would do that. Now, we would do that 4 weeks in a row. And then guess what? We would do another bulbar cavernosa reflex test. Do you know why? I know Debbie knows why. Because at the end of 4 weeks of any kind of physical therapy or rehabilitation, you have to prove that you're improving the patient. There has to be proof that what you're doing is fixing them, right? It's all about fixing them. So the bulbar cavernosa, we found, as we had that 85 millisecond latency at week 1, we would have about a 60 or 55 latency at about week 4. And then we would have, as you all saw, at the end of week 8, a 35 millisecond response or normal response time. So that middle treatment, non-subjectively, was allowing us to be able to say, yes, this treatment is working. The reason that was important was because so many patients, and I mean so many patients, after 4 weeks would not necessarily be seeing symptomatic improvement of their issue. However, if they continued on with the treatment, 4 more weeks, we saw dramatic improvements on the last part of the 4 weeks versus the 4. So to kind of put this in perspective, we checked the muscle, we prescribed proper muscle exercises that they did at home. We assessed each week to confirm that their muscles that they were doing it accurately and that there was improvement. If there wasn't improvement, we would change up the exercises. And we had an objective test that we did on the first visit, basically the 5th visit, and then the final visit of the patient to be able to objectively say, we are helping this patient. And then the results spoke for themselves at the end. So that was the pelvic floor program, basically crunched down into a nutshell on what we did at UNLV Medical School and what we're doing to this day at UNLV Medical School. So any thoughts about that, Debbie? What do you feel about what we're doing out here?
I think that's what pelvic floor rehab has actually, rehabilitation, what anyone wants to call it, has been missing all along. We've not had anything to, number one, tell us, is the patient getting better before they have that symptom improvement, to keep them engaged, number one, so the patient knows what they're doing is helping. But not only that, it tells us that we don't need to change the course of treatment and look at something else because we're actually making progress. Again, everyone too deals with the insurance companies. The insurance company says there wasn't medical necessity. You have proof there was medical necessity. That is improving. It got better at the end. So this is a tool that we have been missing for all of these years in dealing with these pelvic floors and knowing what's been going on with them. It's given us a new look at the treatment, but also it is a confirmation that the treatment is working.
And then we know after, the full 8 weeks, we know the percentage of improvement patients had. I thought it was interesting too, that when we looked at these patients 2 years after the fact, up to 2 years after the fact, and not only had they continued to hold the improvement, they actually give us a higher rating 2 years after the fact, which means that they improved beyond, the end of that at the end of 8 weeks, we asked them, their percentage of improvement. And then 2 years later, they actually got even more better. That means that the improvement continued even after we stopped treating them. Because quite frankly, I think it's because we improved the nerves. We improve those nerves, the body naturally pushes against the pelvic floor, and that muscle knows its job when it can do it to fight back and to continue to strengthen. So I thought that was an incredible part of that process. So, to final up our conversation here, Debbie, do you have anything else to this particular group or to the people that ultimately will be watching this webinar, how you feel? And I know the opinion that we wouldn't be able to honestly do this without your URaval and without your system that you invented so long ago in order to be able to, prove to us that we are doing improvement. Because if not, if I was doing it on symptomatic, I would have lost half of these 95 patients. And that would have been a shame because they wouldn't have seen those final results. in a nutshell, give us your vision. Obviously created a system that really helped out a lot. Where do you see it going from here?
I see this progressing to many other treatments, especially in gynecology. It's very nice to have this. Is there pelvic nerve entrapment? Is the pelvic pain due to an entrapped pelvic? Is the nerve entrapped that's causing the pain? Do a quick test. If the nerve is entrapped, the bulbocavernosus reflex latency time is going to be prolonged. So that's very powerful to know too. If they have had something like trauma to the tailbone, anything that's going to affect that sacral nerve, they come in and, they talk about, well, I'm having some leakage. I'm also having pelvic pain. You don't go get an MRI for that, really. It's hard to see those nerves. It's very expensive. You can do a quick reflex in the office and know exactly what's going on with that sacral nerve, which leads you to the correct treatment. So it's becoming very powerful in many arenas, in pelvic floor, incontinence, and many things in the future as far as how to deal with the reflex and pelvic nerves.
Agreed. Now, I like I said, this webinar was really just kind of between you and me. We were looking for Dr. Levy, but he, must have gotten delayed. And I know how it is when you're in clinic and trying to get through. So we didn't get the chance to enjoy him on this one. We may have him join us on the next one. At this point, if you're open to it, I think there's been a few questions that were asked. I think I'd like to be able to open up to allow some of our guests to be able to ask us some direct questions about, maybe what we did, how we did it, how the URAVAL and the bulbocavernosa reflex system specifically works. So I will, first, before I let everybody know, I'm going to go ahead and read off what people have asked. We have Tamara, who would definitely like the protocol, and I'll make sure that you get that tomorrow. And you asked if we could repeat the information regarding neural versus muscle causes for incontinence. So that's a great question. So how is it that neurological incontinence is different than muscle incontinence? And I would say, from my perspective, and you can join me on this, Debbie, if the nerves aren't firing correctly into the muscles are not going to stand a chance. They're just not. They're going to weaken and continue to weaken. And I think we see that with some of our paraplegic patients, correct? That even with physical therapy, if the nerves are not firing into those muscles, we have a real problem. So if you're just doing something like biofeedback and not addressing the neurological problem, you're only giving those patients temporary relief, and they're not getting permanent fixes to the problem. That's my perspective from what I've seen both in biofeedback and the comparison in biofeedback and direct neurological stimulation using proper stimulation techniques, which aren't currently being done. What do you think about that, Debbie, when that question is asked, the difference between a neural versus a muscle cause for incontinence?
I think that's very accurate. I think the other thing that even more delineates that is when we are looking at treatments, when we know that there is a prolonged latency time, something that probably everyone has heard of, and that's injecting botulinum toxin type A into the bladder muscle for your overactive bladders. Well, if that person's latency time is over 100 milliseconds, rarely, if ever, do they ever become dry with just injecting the muscle. That's because there is, at the root of the problem, it's nerve related. It's that S2 through S4 reflex. So treating the muscle of the bladder is not always totally successful. In fact, rarely if it's over 100 milliseconds. So that helps lead to the right, again, you may want to consider something else if you've got 120 milliseconds and you're looking at that, because this is more nerve related than muscle related.
Right. We can separate out the difference. They even talk about this on the Merck manual a little bit, because when we see before you do urodynamics, for example, you're supposed to know whether or not you're dealing with a neurological issue or a muscle issue before you do urodynamics. And I know a lot of urologists they don't do it. They don't know how to do it. And how they were taught in medical school with the needles, the poking and looking for the response. that doesn't really hold a lot of water when it comes to actually being able to determine improvement and whether or not it is a neurological issue or not. Like you said earlier, Debbie, even people that have neurological issues will have a bulbocavernosa reflex. It just, is it abnormal or not? And how do you know, whether or not you're dealing with a neurological issue or not? So Dr. Kimberly O'Sullivan, we know that when the nerve is injured, the tropical factors, the muscle do not get the muscle, which results in further weakening of the muscle. If the muscle dies to a lack of tropic factors, then there's no way to regrow. So the loss of strength is progressive, I think is what you're after. And she's absolutely right. Once that nerve is not firing into the muscle, it's just a constant battle that's just, you're not going to win. That's why addressing this neurologically makes more sense than addressing it just muscle related. And you don't know if it's a nerve issue if you have not tested that nerve first, as the guidelines say we're supposed to do. So I'm just emphasizing that what Debbie and I are talking about right now and the purposes of her machine are, dead on for what the guidelines tell us we're supposed to do. Now, there are other ways to check the bulbocavernosa reflex, but they're painful, they're non-reimbursable, they're not accurate. There's a lot of reasons that they're not a really good example, and probably a reason you see a lot of urologists and definitely gynecologists simply not doing it. They don't want to put their patients through that. Okay, I've got any other questions. You guys can message them in this this group chat board, or if you'd like, I can go ahead and ask everybody to unmute. And anybody that has a question, feel free to ask, and this is your time to be able to give us some good questions. And if not, then I hope we answered a lot, or maybe we ended up, getting people more more confused.
I'm interested in, oh, sorry, go ahead.
Tamara, I think you were speaking first.
Yeah, I'm interested in more information about the equipment that you're discussing. I haven't heard of it. And actually, I was invited to this meeting by someone who popped into the front office of our physical therapy, said, I heard you have someone who does pelvic floor, dropped off a flyer and left. So I don't even know the name of the person that did that because I was back with patients. But yeah, I'm interested in finding out more about the equipment and about how it might be applicable for physical therapy and like where we're going to go with the patient, or whether this is just not really a physical therapy office piece of equipment, which knowing more about the equipment will help me with.
Absolutely. I think that physical therapy is absolutely a place that's doing pelvic floor rehab is a place that this would make a sense, because it can help guide you a little bit on some more effective processes with your treatment and duplicating what I did at the School of Medicine in your own office, to be able to get some of these really good results. Now, I'm sure you're doing wonderful stuff. If you're a pelvic floor physical therapist, you're amazing. Just so you know, you're amazing. And there are not enough of you in this world, period. But that being said, if you want to hit me with an email, or if you'd like, send me your email as a direct on this chat box that's here if you can, and I will absolutely find out, number one, who dropped it off to you, and I will start giving you the information that you need to be able to kind of make a decision about whether or not the URAVAL is right for you, and maybe relooking at even your techniques, and maybe we can bounce some ideas off of each other. I'm always interested in what other people are doing out there. At the end of the day, we're all looking for the same thing. We want our patients to be successful, and we want them to be dry. That's our goal. So I did get your email, and I will send you an email back. Thank you. Any other questions for anyone? Dr. O'Sullivan, I think you had a question or maybe a comment.
Well, my biggest comment is that I think that the benefit to the obstetrics and gynecology office is to understand when the importance of identifying nerve pathology, because not only does it allow them to counsel their patient effectively, but it also allows them to monitor the physical therapy when they send them out. And then that opens up the conversation with those pelvic floor rehab to consider learning these other protocols.
What a
Um,
good point. What you said is just dead on. One of the things that my urology offices that I talk to, and Tamara, maybe you can comment to this, that one of their biggest problems from their perspective is that they're sending patients out to PT, to pelvic floor physical therapy, and it's just sending them into this black hole. They don't get any real feedback back. And one of the techniques that we talked about doing was from the physical therapist side, is that at that 4-week mark, sending the patient back to the physician that referred and allowing that physician to do another bulbocavenosa reflex test and be able to look at the comparison study and see that nerve's improving, to confirm that, yes, this pelvic floor program that you're doing is working, and to refer them back to you in PT, to allow there to be this really nice line of communication between our physical therapist and our doctors. And I don't think that exists to this day. At least it doesn't here in Las Vegas, to the point where I think a lot of patients are not being referred to pelvic floor physical therapists that should be referred to pelvic floor physical therapists. But Dr. O'Sullivan, is that kind of what you were getting at? I kind of jumped in there.
yeah, that's exactly what I'm getting at. And I think one of the biggest difficulties that I have is the instantaneous, we refer that out to Eurogyne or to PT, rather than understanding that they actually play a role, and they play a very important role because that is the patient's doctor. And so the patient trusts them, and the patient wants to know that they are aware of what's going on in their body so that they can talk to them about the issue. Because most gynecologists and obstetrics and gynecology, they have a very long standing relationship with the patient, which I think serves an enormous impact on the patient's ability or desire to want to open up to them more comfortably than other referring doctors.
I completely agree. I think that when we look at this as a holistic goal to fix our patients, number one, as a physical therapist, you do good work, you're going to get more referrals. It's that simple. Doctors talk to one another, and they love to hear that, oh, I send all my patients to this PT because that PT talks to me and tells me how my patient's doing, versus just fixing them and then calling it a day. This gives an interesting bridge between you and that referring physician when it comes to neurologically testing and objectively being able to determine if there's improvement, as we should give, even before there's subjective improvement. And I think that doctors like to see that kind of data, and they like to hear from the places that they refer to about the patients that they referred to. I think that's one of the big things that we're missing, when it comes to just the relationship between our physical therapists and the doctors that are working. And that's why I like to hear, when I work with people that put these systems in their offices, specifically PT, I like to know where they're getting referral from, because, it can work either way. You can do the bulbocavenosa reflex, or the doctor who refers to you can do the bulbocavenosa reflex, and therefore give you guidance, as these doctors like to do, on ways that are going to be able to help get this patient to dry faster, which is what our goal is in all of this. So, yeah, great.
Yeah, and in Virginia, we have direct access. So some of our patients are coming in without a referral, but I would love to be able to work as a team with a urologist or an OB/GYN or all of the above, right? Because directly, especially older patients and our postpartum patients, they can benefit from pelvic floor rehabilitation. And I'm not sure that everyone in the area is aware that it exists, or that it's being underutilized, and there are not enough there are not enough practitioners for it too.
Right. Yeah, no, I think that
Tamara, I would love to get your feedback. I would love to get your feedback because as a therapist, what is it that makes you willing to listen, that there's something that can allow you to modify your treatment to get a better result? Like, how do we approach people who don't know that this exists, just as you're commenting on the OBGYN or the urogyn who doesn't realize that an old person can do this? What are your recommendations?
Oh, wow, that's a really huge question, isn't it?
Yes.
you put on the
I
spot, right, Tamara?
yeah. Um, you know, I feel like having a partnership where we get to know each other as practitioners is going to help with that. But some patients don't want to go to more than one person for something that private, and we have to make sure the patients understand that there is a way to make a difference. Um, I are you in what what areas is everyone from? Because I feel like this is sort of a national meeting.
Yes.
At least
Yeah.
one other person must be from Virginia.
I think we've got a few supporters out there that can probably help you. I'll find the local rep and make sure that they come in and talk, because somebody came by and gave you that piece of paper. So you're going to get visited by somebody else again here real soon, I promise. But within that, those same people that are talking to you in the physical therapy arena are also talking to those same urologists, gynecologists, and urogynecologists. And those reps are the ones that can help, guide these doctors to start referring to you, because now they've got a tool that can tell them that you are the direction they should be going for this therapy. We need to help a lot more people than we do. I'm always surprised at the number of women that come through UNLV, School of Medicine, and how few number actually end up over on my side. And unfortunately, a lot of that is because we have a lot of students and they need surgeries to be able to ultimately graduate. So I feel like there's a little bit of skewedness there, that they'd rather not send to the person who keeps those people from surgery. I know that's a horrible thing to say, but it just feels like that. And I think if I was a med student, I would not like the non-surgical guy in the room. But that being said, there's definitely not enough people referring out to these types of programs. And something that I think that the Mazon reps that are national, we have about 130 reps in the United States, that those people need to be communicating not only this test, but where they can direct patients to a good pelvic floor rehabilitation or physical therapy program that exists in their area, to be able to just not be selling a piece of equipment, but to be selling a solution to a much bigger problem. That's my take on it. So yeah. So that being said, we're getting very close to the end of this meeting. I really appreciate everybody that stuck on. I'm not sure how interesting me and Debbie's conversation was without Dr. Levy in the room, but I think we tried to do our best. If you have any questions, concerns, comments at all, feel free to check out our website at mazonmedical.com. You can reach out to us. Anybody can leave an email message or request, and this particular webinar will be available on mazonwebinars.com. Mazon, M-A-Z-O-N, webinars with an S.com. So that being said, Debbie, unless you have anything else, I think I'm going to close out our session. Does anybody have any last questions for us before I end this webinar?
I want to thank everyone for tuning in.
Absolutely. Thank you, everybody. Everybody have a great night. Continue to do what's best for patients, and let's try to help, see incontinence go away forever. Have a great night.